Okay, so we're moving on to obsessive compulsive disorder, otherwise known as OCD, and that's how we'll refer to it from now on. I want to make a distinction. There is a pop culture reference to OCD that's very common, and it refers to people who are maybe very neat, very organized, or germophobic. And it's almost put out as some sort of a virtue because they're in control of their external environment. True OCD causes a lot of distress to the people who suffer from it. It is rooted in anxiety disorder. It's a way to externalize that feeling of anxiety, and it can lead to a lot of distress to the patient. It is marked by obsessions and compulsions. Obsessions are these intrusive, recurrent, unwanted thoughts, impulses, or images experienced as stressful. And the person knows that they are unreasonable or irrational, and yet they can't get rid of them. For example, they may see the recurring image of their house on fire, and that's why they need to check all of their rooms and smell for smoke and check the plugs maybe 8 times is the magic number. So they get these obsessions. The checking, the cleaning, the actions that they take are called compulsions. It is something they feel obligated to do. And if they don't do it, they feel that some horrible thing will happen and their stress is not alleviated. So this can be counting. It can be checking things, check the freezer or check the plugs, make sure that nothing's on fire. Constantly washing hands. They know that they've already washed their hands well, and they know that the germs should be gone, and yet they have to wash. And sometimes there's a magic number or ritualistic aspect to this that they have to count them 8 times. And if they touch anything while they're washing, then they have to do it again. It becomes very distressing to the patient because they know that it leads to maybe taking longer to get things done. It interferes with their normal functioning. There are a few variations on OCD, like hair pulling, which is trichotillomania, and hoarding. These are people who excessively pull at hair. It's more than just a bad habit, but they can actually pull out hair until they have bald patches. And people who hoard, who feel that they're never going to have enough, they have to keep acquiring more things. Those are sort of obsessive thoughts leading to compulsive behaviors. So nursing diagnoses that we commonly associate with anxiety, OCD, and related disorders are the diagnosis of anxiety. Now, a nursing diagnosis of anxiety does not diagnose a generalized anxiety disorder or any other thing. What it does is it identifies a state that the nurse can address. So you're not diagnosing anxiety disorder, you're diagnosing a state of anxiety, and then you're going to institute nursing measures that hopefully relieve this anxiety. That's going to be a feature of a lot of care plans, even in the med-surg world. Then we can diagnose panic anxiety, which is a variation. It's just a matter of severity. Powerlessness. The person who suffers from OCD or panic disorder often feels that they're powerless over their own emotional response. So we have to help them acquire some kind of relief for that. And then we can diagnose fear, and fear is when we have an external stimulus. So fear could be your phobias. It could also be fear of death, when the person is diagnosed with a serious illness, fear of disability. But they fear an actual result. And so those would be nursing diagnoses. We also have social isolation. So a person with social anxiety disorder who fears embarrassment all of the time is going to isolate. Agoraphobia, people, again, they don't leave their houses. They're afraid of leaving the house, become very socially isolated, and we have to address that as nurses. Ineffective coping underlies all of these. And when we see the more severe things, and I put OCD in parentheses here, but really any of them can lead to ineffective role performance. If your role is to go out and function in an office and you can't leave your house, well, now you have ineffective role performance. Or if your OCD creates a conflict with your job, you are afraid of being infected with things, and you are, in an environment where you may be infected. Right now, let's say teachers who are afraid to go back in the classroom in that K through 12 environment could suffer from ineffective role performance. Also, people don't tend to perform at their best when they get to moderate severe anxiety levels. And ineffective impulse control mainly affects the OCD variations. This is those compulsions they just can't control, or the person verbalizes that they can't control what they do when it comes to that. They act on that obsession before they can inhibit the response. Outcomes that we're looking for, we want the person to recognize their anxiety when it's at a low level and then intervene. And we want to teach them skills that they can solve this problem before they reach panic level. And you want the person to be self-sufficient with these skills. Like any other skill, you have to practice it in order to be proficient with it. So we're going to help them with that. And we want the person to maintain anxiety at a manageable level and make independent decisions about life situation. And that's when you have longer lasting disorders. Now, if you have somebody who's experiencing an anxiety state in relation to, they're going to the operating room or they're in the emergency room and they don't know what's going to happen and they're starting to escalate a little, then we need some quick relief strategies. It's not always going to be medication based. But that's one of the reasons that the Wellness Project is going to be important to you, because it'll give you an arsenal of tools to use to help people manage their anxiety before it becomes moderate, severe, or panic. You also want the client to function adaptively in the presence of a phobic object or situation without experiencing panic anxiety, and that's more for your phobias. Again, people can go their whole lives without ever getting on an airplane or seeing a snake. But if they have to get in that MRI machine, we're going to have to help them deal with that anxiety. We want them to have a future plan of action. Anxiety is something that can strike without warning, but if it's happening more often than not, we want them to have a plan that works. And that's true of phobias. It's also true of other things, that they need to have a plan. Just like you have an asthma management plan, you should have an anxiety management plan. And you want people who have OCD, to manage their anxiety at a manageable level without resorting to those rituals. Remember that OCD is sort of rooted in a generalized anxiety, and they target this external stimulus. They have the image of the house burning down, or of being crawling with germs, or some other dreadful outcome. So we want them to recognize and lower that anxiety to something that's in the mild range without resorting to those rituals like checking the house 24 times before they can leave, without having to use bleach on every surface in their home. We want them to recognize the triggers and then have a plan for managing it. And then we want them to have adaptive coping strategies rather than ritualistic behaviors in the case of OCD. So interventions. Anxiety can be very contagious. Maintain a calm, non-threatening approach. Check your own pulse before you walk into that room. If you're calm, it helps the patient stay calm. When they see your anxiety rise to their levels, it aggravates and escalates situations. If your patient's having a panic attack, never leave them alone. That can be a terrifying experience, and the person can start to really lose control, and then you'll see behaviors that you don't want to see. So never leave the patient alone during a panic attack. When the person is experiencing the more severe levels of anxiety, communicate in very short, simple sentences. No long lectures, low stimuli. So dimmer lighting. Don't have them in the corridor of the emergency room where everything's going on. If you can silence alarms, that kind of thing would be helpful. And for long-term, teach the client triggers and signs of escalating anxiety. A symptom diary is often very helpful for folks with anxiety disorder. Have them describe when they are experiencing anxiety, what was the trigger, what was the feeling in their body, how bad was it, and how did it resolve. And you're going to teach the client methods of coping, things like journaling for their feelings of anxiety. Mindfulness meditation is very helpful, especially things like the body scan, where people go from their feet all the way up to their head, feeling what's going on in their body, breathing to those areas. Any kind of physical exercise. Sometimes people go out for a run, they feel much better. So for ineffective impulse control, convey a non-judgmental attitude. With OCD, you could see some really unusual behaviors. So it's important not to judge them for those things. Help them practice stress management and offer support and encouragement. And for OCD, we have something called habit reversal training, where you identify the stressor and the trigger and the urge to do it, and then you replace that urge with something competing. They've had success with people with rubber bands on their wrist, and they kind of snap the rubber band to interrupt that thought. So you want to interrupt that impulse before the person acts on it. And the goal is to have a reduction in those behaviors. It doesn't go away all of a sudden. And then you're going to evaluate your effectiveness based on your goals. Did they meet their goals or not? For a client with anxiety, OCD, or a related disorder, gathering information is important. We want to see a reduction in the number of episodes. We want to see a reduction in the severity of episodes. So having them keep a diary of symptoms is really helpful. And it can be a way that we show that person that they are making progress.